Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on available and emerging therapeutic strategies for patients with either early or late relapsed or refractory multiple myeloma. This episode is part of a larger educational program titled New Therapeutic Developments for Relapsed Refractory Multiple Myeloma. During this podcast, Professor Jesús San-Miguel and Dr. Paula Rodriguez-Otero, both from the Universidad de Navarra in Spain, and Professor Katja Weisel from University Medical Center Hamburg-Eppendorf in Germany, will answer questions asked by the audience during a live CCO webinar. The questions cover such important topics as key findings from the DREAM2 trial of belantamab mafodotin, managing ocular toxicity associated with belantamab mafodotin, how responses to idecabtagene vicleucel differ across different patient populations, and selecting therapy for lenalidomide-refractory disease at first relapse. For more information on Professor San-Miguel, Dr. Rodriguez-Otero, and Professor Weisel, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
The first question I see here is in, I believe it's KarMMa, what is the relationship between HR-cyto, RISS, and or triple class refractory status and depth of response?
Okay, so I can take that question. In the forest plot of the KarMMa trial, PFS benefit and overall response rate was shown across all the different subgroups. It is true that revised ISS 3 patients did a little bit less good, and this data is now being analyzed in depth, and probably in the future we will have more answers to these questions. But overall, all patients benefit, but it's true that revised ISS 3 seems to do a little bit worse.
Okay, if I can add to this comment of Dr. Rodriguez, I can say that there is, as you have seen, there is a discrepancy between the response rate in high-risk cytogenetics and revised ISS3, because according to the hazard ratio, to have high-risk cytogenetics is not influencing negatively the response with BB2121. By contrast, the revised ISS3 was apparently as a negative factor. Then we have looked in detail for this discrepancy, and what we had found is that this was not also influenced by LDH, and to a surprise, it was influenced by beta-2 microglobulin, something difficult to explain, and probably need a larger number of patients just to understand this, because the big surprise is that the response rate was equally good, effective, both in patients with high-risk cytogenetic extramedullary disease, and also very important, patients over the age of 65, which indicate that CAR-T therapy can be also used in patients that don't qualify, for instance, for autologous transplant.
Imagine you have all the combinations available. What would you choose in the first relapse in a LEN refractory patient fit enough to receive a triplet?
Okay, if a patient is LEN refractory and is not receiving a triplet, probably my first option will be KD, carfilzomib, dexamethasone. If I have the opportunity to use a triplet, I will use pomalidomide, bortezomib, and dexamethasone nowadays. Probably combination with carfilzomib and a monoclonal antibody, or a proteasome inhibitor like carfilzomib plus an immunomodulatory drug is going to be also effective in this setting.
Thank you. I have a question for Dr. Rodriguez on CAR-T cell therapy. Is CAR-T cell therapy likely to move to frontline over time? Where do you see it fitting into the algorithm over the long term?
Thank you for the question. So yes, I mean, all the development of these therapies is moving forward very quickly. And now we have already trials recruiting patients in a randomized fashion in earlier relapse. And yes, there will be trials with BCMA CAR-T in the setting of frontline therapy. And I can also see a comparison between CAR-T and autologous stem cell transplant. So yes, I think that this is how the field is moving forward.
Thank you, Dr. Rodriguez. And now one for Professor Weisel, similar kind of question, but now it's about melflufen and selinexor. Do you see these regimens moving up the algorithm, for instance, to the third line or perhaps after RVD failure?
Yeah, for melflufen, I think it's too early to really see here. It clearly moving forward. However, for selinexor, we saw just at the recent ASCO and EHA meetings the results of the randomized Boston trial investigating selinexor in combination with bortezomib and dexamethasone versus bortezomib and dexamethasone alone in first to third relapse, where the triplet combinations showed a clear significance in favor for the selinexor bortezomib dex arm in the primary endpoint in progression-free survival. And we also saw that the once-weekly administration and the once-weekly bortezomib schedule seem to be very feasible to use in this patient population. With, as we just heard, the emerging generation of lenalidomide-refractory patients coming out of first-line treatment, this triplet will be an important alternative in earlier relapse treatment, especially for lenalidomide-refractory or monoclonal anti-CD38 refractory myeloma patients.
Thank you, Professor Weisel. Dr. Rodriguez, what is the most relevant piece of information of the updated DREAM2 data?
Okay, so for me, it's duration of response. So even though overall response rate is not very high, it's only around 30% of the patients, which for me is key, is that responses are durable, and median duration of response in the lower dose, that is the dose that has been selected based on the safety efficacy balance, is 11 months, which is long. So I think that this is the most relevant piece of information for me.
Justine, here is Dr. San-Miguel. May I ask a question to Dr. Rodriguez directly?
Yes, of course you may.
Okay. Now, Paula, you have a lot of experience with belantamab, and one of the main issues is the ocular toxicity. How severe is this ocular toxicity, and how can we either prevent or manage more appropriately?
Okay, so this is a very difficult question, but I will do my best. So it's very frequent. So ocular findings in the ophthalmological exams happens in 2/3 of the patients. So this is very frequent. So patients need to go to the ophthalmologist for regular revision. So the mechanism, so how it is produced. So the patient will have like a formation of cysts that start in the periphery of the cornea. And in some patients, those cysts will move to the center of the cornea, and then the patient will suffer from a decreased visual acuity or other symptoms. So it is important to see those cysts that will be seen in an ophthalmological exam. So if those cysts appear and they are relevant, so probably the best way to go is to dose decrease or dose delay, in order to prevent those cysts to get worse. So there is a discrepancy between ocular findings and patient-reported symptoms. So patient-reported symptoms is around 30% when ocular findings happen in 2/3 of the patients. So this needs to be taken into account because it's not something that goes in parallel. And also it is important to note that dry eye or other ocular problems may play a role in this ocular toxicity. So we need to make also the differential diagnosis with the help of the ophthalmologist if those symptoms that the patient refer are related to dry eye or are related to the keratopathy of belantamab. The good news is that those findings, ophthalmologists are now very aware, and we need to educate them to be aware of this finding. But the good news is that if we dose decrease or dose delay, response stays, so responses are stable and the patient is not progressing. So we learned from the DREAM2 study that despite the patient's dose decrease or dose delay, responses were maintained. So this is also an important piece of information, because if we have these ocular findings, so the best way to go is to dose decrease or dose delay, review the patient in close interaction with the ophthalmologist. Some patients never have this ocular toxicity, so patients with glaucoma or other dry eye, diabetes or other ocular problems are at more risk, so those patients need to be followed more carefully. And I think that is all.
Okay, then Paula, can I summarize by saying that if I have patients need to have regular checkup,
especially for the first 4 months.
Okay, and as soon as the patient, in a responding patient, has in the periphery an evident damage, probably to elapse the treatment, to delay the treatment, since the responses are durable, will be a very attractive possibility.
Yes, so they are working in a new classification of the ocular finding with those cysts and the visual acuity. But yes, I mean, those patients need to be followed, and probably, yes, to hold the dose and delay the next dose will be the best way to go in order to prevent further damage in the cornea.
Because, Katja, this is how we handle the peripheral neuropathy in myeloma, and we learn a lot through
Absolutely.
delay and reduction of the dose.
I think we had some challenges in the past. We had the peripheral neuropathy with thalidomide and bortezomib. We had to learn about handling hypertension and potentially also fluid overload in carfilzomib treatments. And we had a long discussion about secondary primary malignancies and lenalidomide-based treatments. So now we have a new challenge. We have the CRS discussion in BITES and CARS. I think from my experience, I can support what Paula said. We learned a lot together with our ophthalmologists, and I see that we gain a routine of supportive care here, which makes it much easier to keep patients now on this important drug.
Thank you.
Thank you very much, Professor San-Miguel, Dr. Rodriguez-Otero, and Professor Weisel. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, New Therapeutic Developments for Relapsed Refractory Multiple Myeloma, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.